Okay.
So, hello everyone, and welcome to ISA Presence this evening. My name is Hannah Blenko, and I'll be moderating this evening. And it's my great pleasure to welcome Oghome Emembo. I'm sorry for the pronunciation. I'm trying hard. She'll present it herself better in a moment. But uh, Oghome has over 20 years' experience supporting and implementing public health development programs in various portfolios across maternal, newborn, child health, sexual reproductive health, and many other areas as well. But today she's going to talk about the project she's been leading on improving Nigeria's capacity to use data to register stillbirths for decision-making speed. So over to you, Oghome.
Thank you very much, Hannah. Good evening again, everyone. And I'm pleased to be able to, just share a bit of what we do in Nigeria. Um, I think I'll start off by just appreciating the ISA for this opportunity. This year makes it 4 years of being an ISA member, and I think it's been a very inspiring, helpful, and encouraging community of practice. So just to say thank you for the opportunity, and I look forward to learning more and doing more with ISA. So long story, basically we are looking at okay, for some reason my slide is not moving, but um, I think that what I'm going to do now is just give you a backdrop to why we do what we do. And to do that, I'm going to be sharing a very brief video clip. It's 1 minute and 20 seconds, just to give you some context and to give you like local context on what happens in Nigeria and basically what inspired the SPEED project to transit from a project to an indigenous nonprofit in Nigeria last year. So enjoy the watch as I share my screen and just put you on the video. Thank you.
garin shi tas amma daga bakin nan a wanzansa zuwa
Sorry, I'll
kansa
just start
to zai
from
yi
the
baki.
beginning. This is subtitled in English, so people just follow through.
Jimla haihuwar da ta yi 21, amma ɗaya ne yanzu a raye. Ana iya haifa yaro ki gan shi lafiya lau, garin shi tas amma daga bakin nan a wanzansa zuwa kansa to zai yi baki. Ko kuma rabin jikinsa hakan ga zai yi baki kirin. Ko kuma daga bakin kunkurun shi zuwa ƙahahun shi zai yi baki kirin. Duk sadda ta haihi ya mace to in za ta koma wata namiji. Akwai cikin da ta ɗauka, likita ya bamu dama duk ƙarshen wata sai mun yi hutu. Ana ganin abin da a cikin nan lahiya lau babu wani abu. Amma duk wanda aka haifa kuma daga ƙarshe sai ka ga ya zo ya koma. Gaskiya ba daɗi. Akwai wanda hawaye na zan zo saboda rashin jin daɗi, kuma sai in tuna kyauta ce Allah ya muna kuma ya anshi abinsa. Amma duk da haka dai ba ni jin daɗi. Saboda yadda aka haife ka kana son kai ma ka haifa, yadda aka rene ka girma kana son ka renar da ɗa shi ma ya girma ya kai ka makka ko ma ya wuce ka. Kowane uba yana da wannan guri a rayuwarsa.
Okay, so thank you, and I'll go back to my presentation. While I'm doing that, just to give a background to what I just shared. In January 2025, more like it, January to February 2025, one of the last activity we had to carry out, on the SPEED project was to do a social media campaign. We had to go to, a community based on evidence, to get content which we're going to use for social media awareness creation and campaign to just, and emphasize the need for a multi-sectoral approach and collective effort towards stillbirth prevention and care in Nigeria. So I had this team of 6 persons go to Zamfara State in Nigeria. Why Zamfara State? It was Zamfara State because we had done an analysis of stillbirth records in Nigeria from 2013, using the FMOH data, the HIS2 data. The data scope was 2014 to 2023, data of 10 years. And from our analysis, that state had the highest rate of stillbirths in Nigeria. So going to that state was based on evidence. We wanted to get evidence-based content to just share with the public, and my team met with bereaved parents, and of course, as you can see, this is a bereaved couple that have experienced 20 stillbirths, not 1, not 2, 20. Now that got me really frozen. Like when I saw this, for them it was content collection, but for me, it was a call to action. It came to me with a voice saying, Oghome, you can't stop now. Like, you really can't stop now. And if you're like me, a number of things came to my mind. I began to ask myself certain questions like, hardly will a woman get over the loss of a baby all her life, little mention 20 times, not 2, not 3, 20 times, 20 whole times. How many episodes of poor perinatal bereavement care did she have to endure? How much of social stigma and shaming has she gone through? How much of mental health challenges has she had to deal with? A lot of things went through my mind, and I began to wish that I was on the field with the team. I began to wish I was there to ask her some questions, talk to her, because I just feel like you cannot have 20 stillbirths in a lifetime and be okay, right? I was just very concerned about her, and I'm so hopeful that sometime in Q4 this year, I plan to meet her and to just see her and be in that state, all things being equal. So this that you just saw birthed the SPEED initiative. SPEED is an abbreviation of Stillbirth Prevention and Care Initiative in Nigeria. And what I'm about to share with you is how our work after being a project fits into the picture in Nigeria in the NIGHT context. So as you already know and you have heard, I'm Oghome Emembo, and I'm the Managing Director of the SPEED Initiative. And just in case you want to have our organizational profile, the QR code on the right, it's a good way to access that. So this slide basically just narrates the fact that the SPEED Initiative is the social response to a self-reported case of a couple who had experienced 20 stillbirths in Nigeria. We're advancing social justice for women, who go through the emotional trauma and, sociocultural shaming. And, we understand the financial implications of stillbirths in Nigeria. We are supporting national and subnational efforts to reduce preventable stillbirths. More importantly, we want to create an enabling environment for respectful and appropriate bereavement care as a stillbirth preventive practice. So this is one of the infographics we developed at the end of our project for our social media campaign. And based on our data analysis, we found out that 1 in 40 pregnancies as of 2023 ended stillbirths in Nigeria. And the northwestern region in Nigeria had the highest burden. And our call to action was to prioritize maternal care, improve care to prevent baby loss, and the FMOH, as you can see, and the Primary Healthcare Development Board supported us. So before I talk about our pathway, it's important for me to give you some local context. You need to know some things about Nigeria. You need to know where we are right now, so you know how, before I go ahead to tell you how our interventions and our program areas will fit in to close the gap. So what you see now on the screen is a map of Nigeria showing you the 6 geopolitical zones in Nigeria. Nigeria has the southeast, the northeast, the south-south region, which is the gray region. The north-central is yellow, and of course the southwest and north are blue and green respectively. So important is that Nigeria is made up of 6 geopolitical zones or regions, if you prefer. If this is a regional variation, just showing and using histograms to back up some of our data findings. If you look here, you will see that the northeast, which is orange, as of 2015, was as high as 82 stillbirths per 1,000 live births in Nigeria. But as at the time we rounded off our data analysis, we found out that the Northwest, as of 2023, was, had the highest burden, okay? And this is at 24. But when we're talking about states specifically in the Northwest, we see some for our state with 53 per 1,000 live births in Nigeria. Another important thing to note here is that obviously, in the last 10 years, the Southwests have kind of, been like role models and stood out in the area of stillbirth prevention. That's where you have the green histograms and the bars. Yeah. So this is to show you the subnational stillbirth landscape in Nigeria. The red zones you see are the zones that have stillbirth rates at 24 per 1,000 live births and over. That's more than 24, which is the north central, based on the map you just saw. And those between 12 and 24, the blue, yeah, which covers some parts of the northeast as well. And the green, the green area, as you can see, we have just 2 states that have been able to achieve the winner targets, and hopefully lower after now. Yeah, so this is just another presentation of all the states in Nigeria, the 37 states, apologies, in Nigeria. And of course, we can see Zamfara State, which is in the north west, ranking highest at 53 per 1,000 live births in Nigeria. And we see Ogun State and Osun States doing well, and obviously with a lot of things that learnings and lessons that I believe that we will be able to support the Ministry of Health with being able to, isolate and reduce. It will be useful to just, understudy some of the things that have happened in those 2 states and see how we can scale them up to the other states that are really burdened with stillbirths in Nigeria. From the UN IGMI data profile, just to give you a global perspective, Nigeria's share of stillbirths in West and Central Africa is 36.2%, which is really, really, quite absurd, right? So I'm bringing it down to the 9 ENAP reduction targets, and just to let you know what our current rates are, and what our Nigeria ENAP reduction targets are. We can see the stillbirth rates, 23.88. The source is the UN IGMI and reports, and of course the newborn mortality rate, neonatal mortality rate at 37.7. Our targets, we hope that in 2028, based on the NINA plan, we're hoping that we can achieve a rate of 19 per 1,000 live births in Nigeria. And of course, for NM reduction targets, we're working towards 17 per 1,000 live births in Nigeria. Yeah, but the forecasts are not so nice. Yeah, and as of 2023, when the NINA plan was updated, Nigeria was at 41. And if we look at the forecasts, we can see that there is a decline here. Even though we have a target of 17, the forecast is saying that at that time, we will not be able to achieve 17. We'll most likely be at 29 in 2028. Before mentioned 2030. So I thought we should also look at, what our annual reduction targets should be, okay? And this is what the NINA plan contains. Between 2000 and 2015, our reduction rate was 2.7. But if we're going to achieve our goal of getting to 17 per 1,000 live births in 2028 and 15 in 2030, we will need to accelerate efforts to ensure that we have an annual reduction target of 5.2%, in the next 5 years. So, and if we're going with business as usual, of course, it's going to be a dead end. We're not going to be able to achieve that. We're going to still be at 23. That's for the neonatal mortality rate. The estimates and projections for stillbirth rates in Nigeria, I had to get from UNIGME because, quite honestly, I was genuinely disappointed to have gone through the latest updates of the NINA plan, which was disseminated in November last year, only to find out that there was no annual reduction target for stillbirths. And when I discovered that gap and a few others, I placed a call to the Director of Child Health and Development, who manages this portfolio. And I also didn't make so much sense from some of the reasons she gave me why they could not, use the same life-safe tools and, get some kind of unit of measurement. Because my question to her was, okay, if we don't have a target per year, what are we measuring? What are we counting? How do we want to get there? So that's, she said there was going to be a review of the documents, and of course they'll have me on board. But I was genuinely disappointed to find that out. But all the same, thank God I was able to get the UNIGME data. So this is presenting what will happen if we have 5 scenarios in Nigeria. Yeah, so if the rate remains constant, which is the red line you can see, we're still going to remain at 23.88, approximately 9 by 2030. Okay. Now, if the current trend remains, which is the orange one, then we're going to be at 22.1 in 2030. Yeah. If we meet the IWENE target, of course, yeah, we're going to be at 12.0. But if we're able to match up to the high income countries and match up to where the high income countries were as of 2023, then we will be able to achieve 2.8. Okay, so this gives us the very gloomy reality of Nigeria's stillbirth crisis and the fact that we actually have a state of emergency. And more importantly, just to tell you what the inferences are straight up, Nigeria is projected to miss the IWENE target by 2030 and only achieve that target by 2087. Sad. Nigeria's stillbirth rate will be 22.1 in 2030, and more sadly, the required annual rate of reduction is 9 times larger than the observed annual rate of reduction in Nigeria. Yeah, and this just buttresses it. So this is where we are now, at a 1.1 annual reduction rate, and this is what is required. So that's why I said it's really dark here, and it's a state of emergency that we find ourselves in Nigeria. So I'll just come back from my detour, of giving you the local context to now go on to the speed pathway to seeing how we fit into this picture, and just to let you have more information on how we intend to close gaps with the government, and just see how we can put in efforts to reduce stillbirths and prevent stillbirths and improve care in Nigeria. So we have one mission. We just want to see pregnancies result in healthy mothers and babies in Nigeria. Our vision is to beyond prevention and care. We want an enabling environment, an environment that is inclusive and responsive to stillbirth prevention and perinatal bereavement care. And our pathways are education, data use, and policy impact. Now, what's our big idea? What's our model? As I said earlier, I was having a brief discussion with Hannah. We want to embed antenatal care support and accountability systems into community-based women's groups. Why? Why community groups? From my bio, you would have noticed that my background is social sciences. I'm very, very interested in how humans think, what kind of information informs their behavior, what are the belief systems that affect their health-seeking behaviors and end up affecting population health. And it's very obvious that, the bond and the strong ties that humans have, we're all, using sociology jargons, we're called social animals. We're all products of interaction, information, belief systems, culture, values that sometimes come from family and association. Now, what a woman with a baby does with information she gets from a health facility most times is overridden by what her community ties and bond will have her do. So when a woman goes to the antenatal care clinic, she goes there, she gets the information, she sees her doctor, and she comes back to a system that determines what she does with the information that she has received. And it's so painful when I think of the fact that, the same community that shapes behavior and attitude and responsive to health seeking and proper care is the same community that a bereaved mother and father goes back to get the shaming and the stigma they have to deal with. It just makes me understand how really complicated the problem is, and the fact that the communities are just a product or reflection of the kind of information or the belief systems they uphold. So communities, back to our model, we need to address this pathway as a strong determinant of stillbirths and stillbirth prevention in Nigeria. And I see it as one of the roots, one of the root causes and one of the pathways that need to really be prioritized. So just to delve a bit more into our core program technical areas, we have 3 of them, which is the community antenatal care, perinatal bereavement care, and research and data use. In this aspect, we want to be able to develop, pilot, and institutionalize and scale community antenatal care by training women's groups to augment gaps in community health services and also encourage health-seeking behavior with the aim of improving antenatal care uptake and adherence. Not just the uptake, the adherence, because the adherence is where data has shown that there's a lot of challenges with. The second technical area we have is perinatal bereavement care. We are hopeful that Nigeria's first perinatal bereavement care protocol, will be developed and disseminated and scaled through our interventions. And we also want to be able to build the capacity of maternal healthcare workers to provide compassionate and respectful bereavement care. Lastly, research and data use, which we're really heavy on. The SPEED project was a core data use project. And that's so important because we cannot reduce what we don't count. So beyond improving data collection and data governance systems, we want to also be able to lead further investigations, clinical and not clinical, into stillbirth causes, preventive measures, and bereavement care gaps to support evidence-based innovations and help decision-making in Nigeria. Yeah, so what we have here is just to show you how our program areas fit into the NIE-ENAP structure and how the NIE-ENAP structure fits into the IWENE strategic objectives. So what we have here are the 5 IWENE strategic objectives, and these are Nigeria's 10 pillars upon which the NIE-ENAP sits on. And right here, these are the SPEED program areas. So for perinatal bereavement care, we're directly linked to governance and stewardship. Yeah, and of course, health promotion and community ownership, because it takes some collective ownership and community participation and governance to be able to implement that in Nigeria. For research and data use, we align with health infrastructure, health information systems, and partnerships for health. And of course, in the aspect of community antenatal care, we align with Nigeria's health promotion and community ownership structure. So this is our implementation approach, which I have said a lot about, but for antenatal care, beyond behavior change communication and health seeking and behavior, we want to also establish a linkage of community accountability structures with the local government authorities and the primary healthcare facilities. There's that gap that has resulted in poor data collection and reporting, because the community health systems in Nigeria are really stretched. They're really stretched and inadequate for the kind of demand that we have. So we're hoping that when we set up that system and we're able to embed our models in the community, in the women's groups, we will be able to also align and institutionalize this model at the community level to help stillbirth prevention and care in Nigeria. For perinatal bereavement care, we want to support the FMOH to pilot and develop the first perinatal bereavement care protocol in Nigeria. We also want to be able to conduct perinatal bereavement care trainings and build the capacity of maternal health care workers, service providers in perinatal bereavement care counseling as a stillbirth prevention measure. And of course, research and data use, we want to conduct clinical and non-clinical studies on stillbirth causes, prevention measures, and perinatal bereavement care to improve pregnancy outcomes. We also want to develop evidence-based innovations to improve data use and translate stillbirth research findings to policy. We're very interested also in developing and publishing thought leadership materials and content to improve knowledge and awareness of stillbirths for use by the global MNCH communities of practice. So just to give you highlights of our impact story, this is the Safe Mom project, which was implemented to commemorate 2025 Pregnancy and Infant Loss Month. Just to give you a backdrop to this project. So while our funding stopped in March, it dawned on me that even the FCT, the capital city of Nigeria, where I live, is not safe either, because our analysis showed a stillbirth rate of 24 per 1,000 live births in this city. So I said, okay, fine. If I don't have funding to do the things we don't have funding to do things we need to do, right here in my immediate environment, I have access. I have relationship with the FMOH and I have access. I can write and request for access for data pool. So we were able to pull the stillbirth data from January 2025 to July 2025 in Abuja. And I got the data analyst to do an analysis. And we found out that an area council called Gwagwalada Area Council, where the University of Abuja is, had the highest stillbirth rates as of last year. So that was what birthed and informed the Safe Mom projects in October 2025. The rate we got was 53 per 1,000 live births after our quantitative analysis of stillbirths data from January to July 2025. So we came up with this intervention, which was just basically to transfer knowledge and enlighten pregnant women about the WHO's guidance on ANC for positive pregnancy experience, ANC uptake and adherence also as a stillbirth preventive practice. So this is just a picture. This is just to show you cross-section of participants engaged at the Safe Mom outreach last year. Impact in numbers, we planned for 100, but we reached out to 120 pregnant women. 18 women had experienced stillbirths and they had tons of questions, I tell you, tons of questions. They were able to receive answers to various questions on self-care myths and misconceptions about stillbirths, sociocultural practices limiting ANC uptake, and how to engage caregivers at the health facilities as well, and it was a very interesting outreach. What stood out for me, if I must say, from this intervention in October last year was a very poor knowledge of risk detection among the women, if I may put it that way, which is one of the things I hope we'll be able to do. I do not know completely what the antenatal care content and the modules contain, but I am inclined to think it's just an inclination. I'm inclined to think that the information they receive is more skewed towards self-care and things to do, nutrition, than being able to detect risk, identify and acknowledge, to understand when something is going wrong, when they have an emergency, and when they need to show up at the facility. That's one of the things I noted from this outreach. Another thing that stood out from this outreach last year was the fact that a lot of facilities in Nigeria do not have enabling and friendly environments for stillbirth prevention and care. We have limited information and on what to do, how the women should engage, where to go to, who to meet when you meet a roadblock, when you go for a scan, or you're told there is no bed space, or you're told your antenatal care visit has to be shifted 2 weeks later and you have an emergency. What should I do? And you go to the facilities here, there's so much information on family planning. I mean, you have so many posters and IEC materials on the walls, on the doors, on the boards, but there's little information, and some of the questions that we had to address. What I had just talked about was Bloomberg philanthropy funding to implement the improve Nigeria's capacity to use data of registered stillbirths from 2023 to 2025. And we had 3 objectives, which thankfully we achieved. We were able to publish a stillbirths dashboard on the Ministry of Health website to make stillbirths data more visible and accessible for decision making. We also produced and disseminated a data report to provide insight into stillbirths trends. And of course, we advocated for relevant policy. We actually had a high-level roundtable meeting with the minister on the 16th of December 2025, where we were able to thankfully achieve policy impact, and we got policy approval for 3 asks. We had 3 calls to actions that the minister approved. So this is just an infographic based on the findings of our project. As you can see, the Northwest is high, it's a danger zone, and the scale of the crisis is here. This is our rate, and 404,305 stillbirths occurred in Nigeria between 2014 and 2023. And this is our call to action. We want quality healthcare, pass the MPTS CBSR Act, increase funding, and empower the communities. right? So this is just one of the things we used, and more by impact stories, talking about systems change achievements by the SPEED project. We're able to achieve the inclusion of the stillbirth data among quarterly reported indicators to the Honorable Minister. We also achieved the expansion of the FMOH's Making Babies Breathe capacity building program to Zamfara State, which had the highest rate at the time. And of course, the inclusion of stillbirth data on the dashboard in the Honorable Minister's office. And you needed to see the look and the smile on his face when we made that request, right? And that's a picture there, yeah, of my team and I from the IHVN and the SPEED project. That's Nigeria's Minister for Health, Professor Muhammad Ali Pate. That's myself beside him, communications manager, data analysts, and developers, and that's the team there. And this is a picture of our stillbirth advocacy core group, which we established and we inaugurated on the 24th of May. We're able to develop and disseminate Nigeria's first stillbirth advocacy toolkit. We cascaded stillbirth prevention messaging from national to subnational leadership of over 7 groups, including faith-based groups, community-based women's groups, and the media. And we also developed and disseminated Nigeria's first evidence-based stillbirth advocacy video animation. We have an animation that we developed and we're able to use for our social media campaign. More about our impact story with the media. We actually trained the media, after our data analysis results, because they play a strong role in media advocacy and awareness creation, and also in data use, right? We understand that role they play. So we're able to produce and publish over 20 media, both print, radio, TV, and social media evidence-based stories on stillbirths in Nigeria. We achieved coverage and reportage and dissemination of all stillbirths data activities, and we're able to cascade the toolkits to media newsroom managers and over 10 media organizations in Nigeria. So these are just other photo speaks just for your view. On the left here, we have the Federal Ministry of Health and the chairman of the Senate Committee on Health unveiling the stillbirth dashboard on the date was unveiled on the 19th of September 2024. Here we have a representative from the World Health Organization, Dr. Femi Ojo. We have representative from Plan International, and of course the Federal Ministry of Health at the unveiling, the official launch and unveiling of the stillbirth dashboard in Nigeria. And this was our stakeholders engagement and kickoff meeting with all CSOs, service providers, FMOH, NHMIS director, faith-based organizations, and key stakeholders. And of course, to the right here, this is Senator Ipalibo, the chairman, Senate Committee on Health. When we had to do a private engagement to onboard her on the project in Nigeria. Here is a photo speak of stakeholders, the advocacy core group, placing their project charter of commitments on a board. Yeah, they're making inputs into the project charter of commitments. That's this Christian Association of Nigeria. That's the Director of Planning, Health Research and Statistics. And Madam Maureen is from the Catholic Women's Organization in Nigeria. And this other person is from a General Hospital in Abuja. And this is me attending to the media. They usually have a lot of questions and comments and things they want to be able to verify before they do their reportage. So that was the official launch and unveiling of the stillbirth dashboard. So in conclusion, we hope to develop more implementing funding and technical partnerships to support our work in Nigeria. Thank you, and over. This is a QR code for our organizational profile, just in case you want to be able to have that at your fingertips. Thank you, and over. I'm open to your questions and comments. Thank you.
Thank you very much for such a whirlwind whistle tour. I think if we could all show our appreciation for that fantastic presentation and overview. Amazing. 2 years and all that you've achieved is absolutely fantastic.
Thank you.
Really going from the community level all the way up to the high level political actors, using data, listening to people, implementation, absolutely fantastic.
Thank
What I'd
you.
like to now is to open the floor to some questions or comments from people. It would be great, I'm sure, to do this. So Michelle has a question first of all. So Michelle is saying she'd love to hear more about your social media strategy.
Okay. So thank you, Michelle. So our social media strategy involved the use of we used the social media platform of IHV and ISA, which was the organization I was affiliated with when I implemented the SPEAK project. And we're active on Instagram, we're active on LinkedIn, and we're also active on Facebook. Right. So those were the three platforms we used to be able to disseminate the content and the messaging we had to just improve public awareness and ensure collective efforts at the time. Unfortunately, it was limited by funding and timing. So that was, that ended with the project. Right now, we're in the process, now that we have transited to an organization, a full-fledged organization, that's something that is in the works. And as time unfolds, we'll be able to come up with a definite pathway for how we intend to engage social media with the interventions that we're able to implement as we get funding going forward. Thank you.
Thanks. And Michelle, do you want to come in there?
Yeah, thanks, Hannah. Thank you so much for your presentation. You've done some incredible work. I'm asking you about social media because I'm always interested whether you got good engagement both from families and from professionals, and if your platforms were able to cross over and include both of those groups.
Yes, so we got good engagements during the social media campaign. We got our highest engagements were from bereaved families, honestly. I remember having to answer tons of questions. The comms team would, signal me and just share the questions that were being asked. And then we had to post, recommendations and answers. So if I want to go by the rates of engagement, the highest level of engagement was from bereaved families during our social media engagements. I think the lowest feedbacks we got was from research institutions and the health, the higher education institutions, and more like, should I call it the professional community? Yeah, we had more from bereaved parents in Nigeria during our social media campaign.
Thank you so much. Thank you.
Yeah, you're welcome, Michelle. Thank you.
Excellent. Do we have questions from others? Comments? Maybe while people are thinking of their questions or comments they want to make, maybe I can ask you another one then. So it's fantastic that you have done so much. You have this advocacy toolkit now in place. I know funding environments are tricky right now. So how are you keeping things going while you're waiting for the next funding?
Yeah, so right now, because the project was able to birth structures, we birthed two groups. We have the Media Against Stillbirths, and then we have the Stillbirths Advocacy Group, right? So somehow we were able to duplicate ourselves in a way, right? Like, into institutions beyond our funding limits. So right now we have WhatsApp group platforms that we use. Yeah, I get updates on stories that are being written on stillbirths. I get invitations to, media engagements. Yeah. And when I'm chanced, I'm able to make it. And sometimes they want to reshare something that was shared before. We're also in close communication with the advocacy group, because the advocacy core group, thank you, Judy, the advocacy core group is made up of different organizations. We call them like, I don't want to call them gatekeepers, but people who have a role to play and some form of influence. Yes, that's the word. Yeah, in their spheres of operation. So I get information and invites to speak from time to time from the Catholic Women's Organization. We get cases where we need to make recommendations and provide some kind of counsel and advice, facility referrals and all that. So it's a bit, because the project is ended, that's definite structure. Yeah, it's and with limited funding, but thankfully we have those two structures: the Media Against Stillbirths and the advocacy group. They are active. In fact, they're just waiting for the word go, and they're gone. So that's what we're doing. Thank you.
Yeah, that's fantastic. So please do put your questions in the chat or raise your hands. We'd love to hear other perspectives and comments or questions. So just following on from that then, so you said you're looking for more funding. How much funding are you looking for, and what would you like to do with it? What's going to make the biggest difference, do you think, in Nigeria?
Please, could you come again, Hannah? I didn't get that.
Sorry. So you said you were looking for funding, and I was wondering, how much funding are you looking for? What do you think will make the biggest difference in Nigeria for stillbirths at the moment?
Wow. That's an interesting question, because when you have nothing, I mean, you're open to anything right now. But if you want me to put figures to it, at the moment, funding within the range of to at least start in the FCT, anything between 100 to 150. Yeah, would help us kickstart something, from here. Yeah, and hopefully we get a multi-year unrestricted funding that a lot of foundations and philanthropists get, and then we can continue our work. But Hannah, I tell you, anything less than that is well covered.
Yeah, so I think we're all there.
Okay.
I think we'll be.
I think I was frozen. Can you hear me?
Yes.
Saying that anything less than that is extremely welcome.
Yeah. So I think I think we'll really appreciate that substantial funding can help go on, and I'm just impressed with what you have done in the 2 years project. So Judy's got a question she wanted to ask now, in terms of what your biggest challenges have been at the community level.
Thank you for that question, Judith. So the biggest challenge at community level so far has been the gap between the gap that culture creates. Let me put it that way. Yeah. So I don't know how much you know about Nigeria, but Nigeria is a very, very culture inclined, like culturally sensitive and responsive country. When you go to the communities, you discover that you need more time to debunk a whole lot of things that are going on, a whole lot of decisions and choices that the women and even the men make that lead to poor fetal outcomes in Nigeria. And these things come in, they come in with a lot of conviction. I mean, you need to hear some women speak to you about some concussions they drink, so first trimester, there are mixtures that, some person in some group in a community makes and gives a woman to take in, and then she has to do the same concussion in the second trimester of her pregnancy, and then she has to put this on her body, and a whole lot of things to deal with that affects human behavior. And human behavior is one of the most difficult things to deal with. It takes time, but it's really doable and practicable, especially when you have evidence, to back it up. So far, that has been one of the challenges at the community. Something else that is a challenge with communities now, especially in the Northwest, is the unrest, and sometimes some insurgents make those areas of Nigeria a bit unsafe and inaccessible as well. And that also affects access to the facilities too. Yeah. A number of publications I have come across, trying to, provide, evidence on the impact and the effect of distance between, communities and facilities, and how it, the influence of stillbirth rates in Nigeria also points to that. So those are the two things I can tell you about for now, Judith. And it's great, it's interesting to know that you're in Nigeria.
Excellent. So I've got another question for you. I mean, one thing that struck me right at the beginning was when you were presenting the stillbirth rates, and you had rates of 8 in one state up to, I think it was 53. Real disparity between them. So Nigeria it's one country, but it's lots of different things driving that difference, I'm sure. So how, as an organisation, or how do you think different approaches are needed in different parts of Nigeria? How could things be tailored?
Yeah, so different approaches. For instance, looking at the Northwest, the approach has to be a lot of education and understandable education. You have to consider the data literacy levels of the people living there. Data needs to be broken down to really understandable formats, right? And communicated to the decision makers at decision-making level, and also at the grassroots to the women who are the project-affected communities, right? That's for the Northwest. Now, for the South, in Nigeria, that seems to be doing well, we need to take time to understand the time frames, the leadership structure, whose administration. We were able to identify who was in leadership when in Osun State and Ogun State, and has resulted in this quite, positive outcomes in those states. And then we have identified the governors, and by the time we began to investigate, we saw that there were a whole lot of implementing partnerships and interventions in those states at community level that resulted to those good rates. Yeah. So those sites will be more like study sites that will help us scale and duplicate whatever has been done to the other geopolitical zones in Nigeria. When I look at the South, where I am from, Hannah, we had the highest rate of macerated stillbirths in Delta State, where I'm from. And we're people prone to alcoholism and substance use. Yeah. So I'm from a state where women wake up in the morning and, they call it wakening up the body. It's like if you have a cup of tea, no, the body is not warm enough. So they have to take some really strong spirits on their pregnancies, and that is done every day. Right. And then there's a lot of substance use, a lot of smoking and all that. Yeah. So these are things that need to be factored into the approach of, sensitizing. And it will be so lovely to be able to just check the programs, the already existing programs, and programs being implemented by the State Primary Healthcare Board, to see how responsive those programs are to those realities on ground. So yes, it has to be different approaches for the different political zones in Nigeria, yeah, if we're going to deal with this problem.
Great, fantastic to hear your insights. And there's really the question just there. I've got one last question for you, Oghome. It's fantastic, and obviously your focus has been on the community and community interventions, but we do know that women need to get to facilities, and it's facility interventions that can save lives ultimately. So are you working at all with obstetricians, midwives, or any other health providers in your work on stillbirth?
Yes, we are. Yes. So we're working with them. We had engaged the Pediatric Association of Nigeria. We have also engaged with the Hospital Management Board here. Obviously, the Federal Ministry of Health. So the community is just one determinant, right? There's a whole lot to do at the facility level, and there's no way we're going to be able to achieve our goals without working with the health professionals and the facilities. And if you remember, when I was going through the slides, we talked about capacity building and training. Yeah. We hope to be able to build capacity, especially in the area of perinatal bereavement care, and also see how we can identify gaps as well at facility level that can lead to, I don't know, 20 stillbirths in a lifetime, Hannah. Yeah, so yes, the answer is yes, we're working with them.
Fantastic. As I said, it's an amazing amount of work you're doing, and really do want to wish you all the best. And I think you were saying at the end that you're looking for more funding and technical support and working with others. So that's the fantastic thing about ISA, is we can be working together, supporting, learning from each other, and fundraising together as well. So looking forward to working more closely and hearing more of the work going forward. So I think we could all now join hands to thank very much Oghome, and we will.
Thank you.
Thank you so much.
Thank
and we look forward to the next ISA Presents. Please join us for that again. So thank you very much. Good night, everybody.
Thank you. Thank you. Good night. Thank you. Bye.